Welcome to Emergency Insights. I'm James Carter. Today, we're tackling a common yet critical emergency, warfarin overdose. With us is Dr. Emily Wang, an expert in clinical toxicology. Dr. Wang, thank you for joining us.
Thanks for having me, James. It's a pleasure to be here.
Let's start with the basics. Warfarin is a widely used anticoagulant. Why is an overdose so concerning?
Well, James, warfarin is an oral anticoagulant and a vitamin K antagonist. Its primary job is to prevent and treat clotting disorders by inhibiting the synthesis of vitamin K-dependent clotting factors, specifically factors 2, 7, 9, and 10. The concern with overdose stems from its narrow therapeutic window. A slight miscalculation or an intentional overdose can quickly lead to an elevated INR, which means the blood's clotting ability is significantly reduced, putting the patient at risk for severe and sometimes life-threatening bleeding.
That's a serious risk. What are some of the common scenarios or risk factors that lead to an overdose?
We see a few common culprits. Drug interactions are a big one, particularly with antibiotics, antifungals, or even common over-the-counter medications like NSAIDs. A patient's comorbidities, such as liver or kidney disease, or even alcohol use can affect how they metabolize the drug. We also see increased risk in the elderly and with sudden changes in diet, which can either potentiate or reduce warfarin's effects.
So if a patient presents to the ER, what are the key clinical signs we should be looking for?
The presentation can vary dramatically. It might be as mild as easy bruising or spontaneous bruises. You might also see blood in the urine, nosebleeds, or gum bleeding. In more severe cases, we're talking about gastrointestinal bleeding, which could present as bloody or black tarry stools, or even intracranial hemorrhage. The first step is always to take a very detailed history, focusing on the warfarin dose, when the last dose was, and any other medications they've taken.
And once we have a suspicion, what's the first step in the diagnostic workup?
After a quick history and physical exam to assess their hemodynamic status, the most critical lab test is the INR and PT. The INR is our primary diagnostic tool. It's important to remember that the INR may not peak for 12 to 24 hours after ingestion, so it's not a one-and-done test. We need to do a complete blood count to check for anemia, and we also want to look at their renal and liver function.
You mentioned repeated INR checks. What's the recommended monitoring protocol?
We recommend checking the INR at presentation and then every 6 hours for the next 24 to 48 hours. A normal INR at 48 hours is a good sign and can often exclude significant toxicity in a patient who is new to warfarin. However, if the patient had a massive ingestion or is showing symptoms, we need to continue frequent monitoring.
Let's move on to treatment. What are the management principles, especially in an emergency setting?
The immediate priority is always stabilization. That means supporting the patient's airway, breathing, and circulation, and getting an IV line in. Of course, the first and most obvious step is to stop the warfarin immediately. For decontamination, activated charcoal can be considered if the patient presents within 1 hour of ingestion, but its effectiveness is limited due to how quickly warfarin is absorbed.
When do we reach for the antidotes? What are they?
The cornerstone of treatment is vitamin K. For patients with an elevated INR but no bleeding, we can usually give a small dose, 1 to 5 milligrams, orally. For higher INR or minor bleeding, we use a slightly larger dose, usually 2.5 to 10 milligrams, which can be given orally or intravenously. But for major or life-threatening bleeding, we immediately administer 10 milligrams of intravenous vitamin K.
What about blood product support?
That's where we bring in fresh frozen plasma, or even better, prothrombin complex concentrate, PCC. FFP is used for rapid INR correction in actively bleeding patients. However, PCC is often the preferred choice, especially in severe or life-threatening situations, because it works much faster and you can administer a smaller volume.
This all seems very time-sensitive. How long should we be monitoring a patient after treatment?
Monitoring is key. Because warfarin's half-life is longer than that of vitamin K, we must watch for rebound INR elevation. We continue to check the INR every 6 hours until it's stable and within a safe range. In cases of a very large overdose, prolonged monitoring for a few days may be necessary.
And what about special populations or unique situations?
We have to be thoughtful. For patients who need ongoing anticoagulation, we have to carefully titrate the vitamin K to avoid overcorrection, and we may need to plan for a temporary bridging therapy with another anticoagulant. For intentional overdoses, it's crucial to arrange a psychiatric assessment before discharge. We also need to provide thorough education to the patient and their family to prevent future accidents.
So, to sum up for our listeners, what are the most critical takeaways from managing a warfarin overdose?
The key points are, first, diagnose with a high suspicion using the INR and clinical signs of bleeding. Second, administer early vitamin K. Third, for severe or life-threatening bleeds, use rapid reversal agents like PCC or FFP along with intravenous vitamin K. Fourth, monitor the INR closely for at least 48 hours for rebound, and always remember the importance of patient education and psychiatric evaluation. This holistic approach saves lives.
Dr. Emily Wang, thank you for these invaluable insights. Your expertise is crucial for our listeners.
My pleasure, James. Thank you.
That's all the time we have for this episode of Emergency Insights. Stay safe and stay informed.